and also showing dense acoustic shadowing. So this is very typical for malignancy. If such a malignancy, if such a lesion is present within the glandular tissue, we won't be able to appreciate it on the mammogram. So again, the importance of screening in dense breast is very important. It highlights its importance. And we all know that breast density and there's a relationship between breast density and cancer detection has been studied, and it's an inverse relationship. So again, all the more importance for screening dense breast. To avoid missed cancers and also interval cancers, which if projected later will be more aggressive. And this is the clinical drive behind the push for supplemental and novel screening modalities. Now, our first novel screening modality is MBI. It is molecular functional imaging, and this is a compact gamma camera system which is optimized for breast imaging. We have two rows of detectors, double head gamma camera, and the breast, it is a dedicated unit for breast screening. So molecular breast imaging is a nuclear-based functional imaging. It focuses on the functional image, that is, it relies not on the tissue density but on the cellular activity. Radio tracer is injected intravenously, and which is taken up avidly by rapidly dividing cells. Hence, it makes it particularly useful in women with dense breasts. So this is a very comfortable procedure. It requires minimal preparation. A small quantity of radio tracer, technetium 99 m cestamide in small amounts, is injected intravenously, and the tracer preferentially accumulates in the fast-growing cells, cancer cells, and the gamma camera takes up the increased uptake, which appear as bright spots on the images. The patient, very little minimal preparation is required. Patient is asked to avoid food and non-clear drinks for 3 hours prior to the exam, and the patient should be well hydrated. An IV line is secured and the tracer is injected. Following a short interval of 3 to 5 minutes, imaging takes, the patient is exposed to the gamma camera. The gamma camera picks up the radio tracer uptake, and imaging may take up to from 20 to 40 minutes. And it is a safe procedure. The radiation exposure from the radio tracer uptake is within permissible limits. Allergic reactions are very rare, and it has high cancer detection rates, irrespective of the density of the breast. This graph shows that this graph shows a study where when 1,000 women were subjected to mammogram, the conventional screening mammograms. The number of patients detected are shown in pink, while when supplemental imaging was added, you can then see the number of patients detected on supplemental ultrasound, MBI, contrast-enhanced mammography, and MRI. The number increased. This again highlights that digital mammography in dense breast is not the investigation of choice, and it needs to be complemented with other modalities. And according to the mandate, the recent FDA mandate in September 2024, while writing the reports for mammogram, it is important to point out the category of the breast parenchyma, and also to apprise the patient that she needs to go for supplemental imaging for better evaluation and for cancer detection. Studies also show that MBI detects up to 90% of cancers in women, and even less than 10 millimeter cancers are picked up on MBI imaging. It detects 2 to 3 times more cancers than mammography alone, and it is not affected by tissue density. Now, in this image, you can well appreciate there's the MLO view in the digital mammography. You can see asymmetric density in the upper quadrant, which is very well shown on the MBI image as area of increased uptake, and at the same time another 10 mm focus is also showing increased activity. So this was a satellite nodule which was not picked up on conventional mammogram. Again, this makes MBI a powerful supplemental screening tool. Another image showing you the mammogram image as well as the MBI image. It's very hard to pick up subtle lesions on the dense mammogram, it's a heterogeneous cardiac list, while MBI will pick up avidly enhancing, highly dividing cancer cells, uh, aiding us to identify cancers in a dense breast. The second modality which I will talk about is ultra-fast MRI. It's a novel contrast-enhanced MRI technique that focuses on earliest phase of contrast enhancement. Instead of long multi-phase acquisitions, it captures rapid enhancement patterns that are characteristic of malignancy, allowing sensitivity with much shorter scan times. MRI, it captures the kinetic information within the first minute after contrast injection. That is within 3 to 10 seconds using a high temporal resolution, and instead of relying on conventional washout characteristics which we employ in the routine mammogram, it allows the analysis of washed-in curves reflecting the contrast inflow effects in an region. Less sequences are required as compared to the conventional MRI, so less time in acquisition of the images. Ultrafast sequences like DISC, TWIST, PID, I won't go into the details. These are employed, and various parameters that can be derived are maximum score, denoted as MS, and time to enhancement among the most frequently analyzed parameters to calculate the inflow contrast enhancement. Basically, it captures the relative increase in percentage increase in enhancement per unit time, and with this help of this, I won't go into the detail of the physics, it can actually categorize lesions whether they are benign or malignant. The enhancing lesions can be well appreciated. It enables the precise differentiation of breast lesions, hence it is also useful for the follow-up of women with personal history of breast cancer. It is also useful in neoadjuvant therapy response evaluation. Side by side, in addition to ultra-fast MRI, we have an abbreviated breast MRI option as well. In abbreviated breast MRI, we have reduced the number of sequences that we acquire during breast examination, MR examination, which helps in shortening the time for the in the acquisition of images, and the results are equivocal with the conventional MRI. The sequence acquired are axial fat saturated T2 weighted sequence, pre-contrast T1 weighted sequence, and axial post-contrast T1 weighted sequence with maximum intensity projection and subtraction images. And these sequences can be acquired in less than 10 minutes. So abbreviated MRI can be employed in our setups where we have MRI suites in the government as well as the private setups. Ultrafast MRI, obviously we need to have software, and that's a tedious task. We don't have that ability. But I think we can work on this, and that would be a great help, especially in screening of young women who have glandular breast parenchyma, and digital mammography does not help in evaluation of symptoms. But obviously, as I am discussing novel modalities, I strongly believe in a dedicated ultrasound in experienced hands, which is very helpful in complementing our conventional screening methods. An image of ultrafast MRI compared with the standard MRI, you can really appreciate the region has been highlighted, which was a very short duration of MRI technique, and the similar lesion was highlighted on the conventional standard MRI, and we also appreciate the small satellite model just deep to it, just like in the conventional standard MRI. Conventional standard MRI takes 20 to 30 minutes during the acquisition, while ultrafast MRI is conducted in very less than 10 minutes. So it's not limited by breast density, it has high sensitivity for invasive cancer, and the acquisition time is less than 10 minutes. And because it can categorize the lesions, so it helps us also in reducing the false positive cases. So it is again an additional help in screening of dense breast. Diagnostic performance of ultrafast MRI. Multiple studies have shown that detection rates are comparable to the full diagnostic MRI because it emphasizes early enhancement and it distinguishes benign from malignant lesions. more efficiently, reducing false positives. Over here, there's a very subtle finding. I don't know in the lights, somebody radiology ki pictures are not very clear, but there are two enhancing lesions in the retroareolar region, also picked up on ultrafast MRI. I think I should have asked to lights uncovered, it would have been much clearer. But basically, multiple studies have shown that the results are comparable. So it's very important in screening dense breast that we should opt for the optimal investigation, which will help in overcoming any small cancerous lesion and avoiding missed cancers and later on avoiding internal cancers. So here's the comparison. The conventional screening protocol, the dense mammogram, which was regarded as negative, but an MBI image showing average enhancement of a relatively large lesion in the retroareolar region, while the left breast is normal, and the contrast image of ultrafast MRI showing enhancing lesion in the similar location. So we conclude while the left breast is normal. So MBI and ultrafast MRI solve the density problem in different ways. MBI detects metabolic activity while MRI detects vascularity and enhancement kinetics. Rather than comparing these modalities, these are complementary and choice depends on patient factors, access, cost and contraindications. In MBI, radiotracer uptake is used and there is only mild compression of breast, while in MRI we have dedicated breast coils with the breast hand and there is no compression. The MRI is very sensitive and rapidly acquired. So the take-home message is that dense breast tissue significantly limits mammographic cancer detection. MBI and ultrafast MRI are two evidence-based modalities that overcome this limitation. Moving forward, the future of breast cancer screening lies in individualized, risk-adapted, multimodality imaging. Thank you for your patient listening. If there are any questions, I'll be happy to answer. Sequences. I was talking with my radiology colleagues, Dr. Isha and Dr. Shabbat. I think we can go forward with the abbreviated MRI so that we can have abbreviated MRI for screening purpose of young females and their breast. That's an option which we can go for.
If we are not provided with these ultra-modern modalities, then what alternate we are supposed to do?
First of all, I would thank Dr. Professor Uzair to keeping us abreast.
So please सब लोग पहले अपने आप को इंट्रोड्यूस कर दें और उसके बाद क्वेश्चन जरूर पूछें. The main idea of this the 2-day workshop or the course is to actually see what is actually happening and novel चीज क्या क्या चीजें हैं. So एक बार जब हमें पता चल जाएगा then we start looking कि ये कैसे होगा और कैसे आएंगी चीजें. So there are so many things that are new first time मैंने सुनी. So ये फिर हमें तभी पता चलेगा जब उसकी जरूरत पता चलती है. क्वेश्चन भी.
I'm extremely sorry, ma'am, for abruptly putting up the question without introducing myself. I'm a fellow breast surgery, private teaching hospital, Peshawar, and my name is Ilmaz Afiki. I wanted to know, you have shown us a new insight on these ultra new.
Yes.
If we are not provided with these ultra-modern facilities or imaging, then will we stick to the former one, or what alternate we have?
Actually, we have changed the micro sequence. Dr. Isha is going to present some very important modalities which will answer your question. In my case, thank you, Dr. Zaid, for keeping us abreast with what is happening around the world. It's also important to keep abreast with the newer advancements and modalities. For my talk, I have shown you a slide where complementary, we are doing so many tests, which includes dedicated ultrasound without its advanced and mother facilities available and this way. I don't believe much that, but my past doctor and elastography will complement me. Other than that, Dr. Isha is going to discuss 3D tomography, digital tomosynthesis, and quantum-enhanced mammography, which are available here. And for my talk, we are thinking of going for abbreviated MRI, which probably we can go ahead with it and use MRI with a limited number of sequences and less acquisition time to stain tests. Technician 99 and system EB.
मैं डॉक्टर तैयारी हूँ ब्रेस्ट फेलो थेरेपी के हॉस्पिटल के साथ मेरे क्वेश्चन है जो एमडीआई आप यूज़ करते हैं उसमें हम कौन से रेडियोप्रेशर यूज़ करते हैं
उसमें हम टेक्नीशियन 99 एंड लेबल सिस्टम EB रेडियोप्रेशर यूज़ कर रहे हैं इनिशियली ये कार्डियक इमेजिंग के लिए यूज़ होना शुरू हुआ था और इट वाज रिकॉग्नाइज्ड इट इज टेकन अप बाय द ब्रेस्ट टिश्यू बाय द पैराथायरॉइड बाय द लंग कैंसर एज वेल फिर इसको मॉडिफाई करके फॉर ब्रेस्ट इमेजिंग के लिए इसको बनाया गया और इसकी अब इतनी इम्प्रूवमेंट हो गया कि इट वाज स्मॉल क्वांटिटी स्मॉल अमाउंट ऑफ रेडियोप्रेशर इंजेक्टेड and even the radiation dose this patient can make that is within the permissible limit, so it's very safe. इसको इंजेक्ट करने के 3 to 5 मिनट्स के बाद में हम गैमा इमेजिंग स्टार्ट कर देते हैं जस्ट 5 मिनट्स के बाद में The gamma imaging takes time, 20 to 40 minutes. Most images, they are reciprocated. We get MLO as well as CCU, so in fact comparison with the radiation mammography हो जाता है. So usually these modalities recommend you supplements. But way forward, inshallah, moving forward, आएगा हम patient की risk stratification or taking into account all the costs and everything, हम शायद हम उनकी स्क्रीनिंग को modify करेंगे according to the patient.
Thank you.
If you have any other questions, तो पार्टिकली देगा और फिर हम प्रेजेंटर को भेज देंगे और वहाँ से मतलब तो अगर कोई क्वेश्चन आपके और ज़हन में आता है तो उसको ज़रूर लिख लीजिएगा, ग्रुप पे शेयर कर दीजिएगा और रेलेवेंट प्रेजेंटर से हम पूछ के उसके ऊपर के वैसे हम आपको उसका आंसर करते हैं. ठीक है मैडम, थैंक यू सो मच.
Right. So moving on, presenter is Dr. Isha Tahir. She will be discussing talk on digital breast tomosynthesis and contrast enhanced photography. Just a brief intro to introduce Dr. Isha Tahir. She is an experienced breast radiologist with over a decade of expertise in early detection and diagnosis of breast cancer. She leads multiple one breast clinics delivering integrated diagnostic services that combine clinical assessment, advanced imaging, and image-guided interventions. She worked across both hospital and private practice settings and deeply committed to accurate, timely, and patient-centered care. I welcome Dr. Isha Tahir to the podium, please.
Thank you very much for having me. And it is very interesting to see that the crowd is very interactive, and I'm really enjoying this. So the topic assigned to me was about digital breast tomosynthesis and contrast enhanced mammography.
Voice is not clear, too much noise.
माइक लगाना पड़ेगा, माइक कनेक्ट करना पड़ेगा. अगर माइक ऑक्स केबल में मिल जाती है एक्स्ट्रा तो उसके
I have no financial disclosures. Only an emotional attachment to fatty breasts, but we all love fatty breasts. study, most of our patients disagree. So whatever recent advances that have been happening in the world, they are focused on dense breast, because dense breast is the bane of our existence as radiologists. It's the very in radiology, especially in breast radiology, and everything that you are going to see, everything that you're going to move forward, and moving forward from here, we're going to see that it is focused on C and D breast. C and D not good for a breast radiologist. So to counter that, we have DBT was launched. It was like around 20 years ago that DBT was first introduced, and now in most of the centers of the world, screening is done with DBT. DBT is not a new technology. It is relatively new in Pakistan. We just have I think around 4 centers in Lahore. But other than that, in the entire world, DBT is the modality of choice for dense breast, and it is being used in screening all over the world. So what exactly is a DBT? How is it different from routine mammogram? So what a DBT does is, a DBT, your normal X-ray mammogram or a digital mammogram would compress the breast between two plates and acquire spot images from two views. But a DBT is different. A DBT would compress the breast in a similar way, but the X-ray tube is going to move in an arc around the breast. The arc can be anywhere between 5 to 60 degrees depending on the provider. It can be around from 11 to 60 degrees or from 5 to 50 degrees. So there are different angles for that X-ray tube movement. And after that, we reconstruct those slices into 1 millimeter sections, and then we can scroll them and we can look at the images on the screen. I'm going to first tell you, yes, this is what a DBT would look like. The orange thing is the breast, which is compressed between two plates, and this is the X-ray tube, which moves in an arc around the breast. A DBT, radiation dose of a DBT is comparable to that of standard mammography, so we are good there. The indications would be for screening as well as diagnostic purposes. In screening, I've already told you dense breast, C and D, baseline screening, if there are any inconclusive mammograms, and also to reduce recall rate. Recall rate means in busy centers of the world, only mammogram is performed. Ultrasound is not complemented by ultrasound. The patient goes back home, and if the patient needs an ultrasound, the patient has to be recalled. So to reduce those recall rates, DBT was very effective in that. We didn't have to recall a lot of patients. In the diagnostic realm, we can look at focal asymmetries, any architectural distortions, small masses, any post-surgical breast, and it is also used as a problem-solving tool. I'm sorry, this is very slow. So this is an example from digital mammography and comparing it with the DBT. The image on the right shows heterogeneously dense breast. Nothing much can be seen on that image. But when we perform a DBT of this patient, you can see that there is an area of architectural distortion, asymmetry in the upper half of the breast. Another example, heterogeneously dense breast, nothing much can be seen. It is inconclusive on routine mammogram, but when we perform the DBT, we can see that there is a spiculated mass in the posterior 1/3 of the breast. It's pretty obvious here. Another horribly dense mammogram, nothing can be seen, but on the DBT we can see that there is, what do we call it, an area of architectural distortion. We can even call it a spiculated mass because there is a mass-like thing in between. So it is pretty obvious on the DBT. So advantages, as we discussed earlier, reduce as a problem-solving tool, we can look at all the architectural distortions, better lesion visualization, and better localization. The limitations are, it takes double the time as compared to a simple mammography. It does not give us any functional information. There are motion artifacts, a lot of data needs storage, and takes double reading time as well. That brings us to contrast-enhanced mammography. Contrast-enhanced imaging is familiar to most of the surgeons or oncologists here because CT scan has been there for ages.
We know that we inject a contrast material into the patient and then we acquire images. This is a standard way in which a contrast enhanced study works. A contrast enhanced mammography is a bit different. We do inject a contrast in the patient, that is iodinated contrast, the same one that is used in a CT scan. We inject that contrast, but two sets of images are required. One is a low energy image and the other is a high energy image. After getting those images, we recombine those images. And once we recombine those images, we subtract the normal breast tissue, so only the enhanced lesions, they are highlighted, so it is like a maximum intensity projection kind of an image. I'm going to show you. We'll just skip these. So this is what a machine looks like. It's just like a routine mammogram machine and it has an injector in place. The contrast is injected and two sets of images are acquired, low energy exposure, high energy exposure and a recombined image. So what comes out is a beautiful image. All the breast tissue is subtracted. Looks like a fatty breast, but a few things are enhancing, which are then obviously correlated. 1.5 milligram per kg body weight, contrast is administered at 2 to 5 milliliters per. The images are required 2 to 8 minutes post-contrast, because that is the time when the contrast is going to enter into the breast. So, like I said, each breast requires 4 images, 2 CC views, 2 MLO views for the right breast and 2 CC 2 MLO views for the left breast. So yes, obviously the radiation dose would increase to 1.5 times the normal radiation dose for a DBT mammogram. So I'm going to show you a few images so that you can appreciate what a contrast enhanced mammography looks like. This is a heterogeneously dense breast on the left side, and you can see that nothing much is visible here. But when we perform the contrast enhanced mammography, we can see after subtraction of all the images, we can see that there are multiple lesions in both breasts, which have taken up contrast. Followed by that, horribly dense breast on conventional mammography. In the upper images, this was followed by DBT. In the DBT, you can see that there is an area of architectural distortion in the central aspect of the breast. And when this patient underwent contrast enhanced mammography, we saw that it was not just one lesion, but multiple lesions. There were satellites as well. So it's pretty good, pretty sensitive. The indications, indications of contrast enhanced mammography, easy to remember, is that all the indications of a breast MRI fit into the indications of a contrast enhanced mammography other than screening. World over, screening is being done with breast MRI for dense breast for younger patients, but as of now, contrast enhanced mammography is not being used for screening purposes. So it has two impacts on surgery, impacts post-neoadjuvant chemotherapy. On surgery, yes, for sure, better size estimation, it improves the surgical planning, and it detects multifocal and multicentric disease. Because it is a functional study, it takes up contrast, so we know that that this is a functional study. So its role in post-neoadjuvant chemotherapy is also very important. We can follow these patients up with another contrast enhanced mammography to assess the response to treatment. So I took the liberty to add another modality, which I thought was important for everybody here to know because it is relatively new. It is the breast CT. Most of you have not heard about the breast CT, but it is an upcoming modality. It is where breast imaging is going to be in another 10 to 15 years. So it was important that we discuss it on this platform. So what exactly is a breast CT? We have already talked about the tomosynthesis. We know that the X-ray tube moves in an arc around the breast, but a breast CT would take it next step. It would move 360 degrees around the breast. The patient would lie prone just like in a breast MRI machine, and one breast is imaged at a time post-contrast. So the X-ray, the CT tube, it moves in a 360 degree around the breast. So obviously it has got better orthotopic resolution. So the advantages and uses are that it can be used in diagnostic workup, surgical planning, no compression is needed, the scan is very fast, 7 to 12 seconds as compared to MRI, which takes around 20 to 40 minutes, anywhere between that. Better visualization in implant, because nowadays, because of breast conservation surgeries, we are looking at breast implants a lot. So it's very helpful there. So this is a beautiful image of a breast CT. You can look at the coronal, you can look at the sagittal, the axial views, and coronal view is important because this is the view that the surgeon looks at the patient in the operating room. Another example from a breast CT. We can look at a speculated mass in the posterior one-third of the breast, and it also shows a satellite lesion which is marked by the curved arrow. Another important aspect of a breast CT is that it can pick up microcalcifications as good as a mammogram, which is very important. In a breast MRI, DCIS will only show enhancement. We cannot comment on calcifications on a breast MRI. So, but in breast CT, in this image you can see that there is an area of asymmetry, there are microcalcifications. The left side is a mammogram, and on the right you can see that a good correlate can be seen on a breast CT scan. Radiation dose, yes, that's a problem. 1.5 times the normal dose for a mammogram, but this is the same radiation dose that is present in a contrast enhanced mammography as well. So limitations, abortion is positional challenge. Patient, nobody likes to lie prone on a table, so that is one of the challenges. Maybe that will be addressed in the near future. A question can arise. Do I have time? Do I have 2 minutes? Okay, the next question would arise, why do a breast CT when you are already doing a DBT? What is the added advantage of a breast CT? So to address that, I made this table. The breast CT is rotation, it has orthotopic resolution, there is full 3D accuracy as a DBT which does not have a full 3D accuracy. The tissue overlap, which is rapidly reduced in a DBT, is totally eliminated in a breast CT. And its future potential is transformational. Another question would arise, why do a breast CT when you can do a breast MRI? So the first and foremost thing is time. Breast MRI is very problematic for the patient, whether they accept it or not. Patients are not happy to get a breast MRI. Patients are claustrophobic. They do not want to lie on the table. A breast CT machine, as you can see, it does not have a gantry. It's like an open machine, and patient has to lie in a prone position for like a maximum of 2 minutes. Nothing more than that. MRI is not easily available everywhere. Breast CT is still not available, but the studies which are done abroad show that a breast CT costs less than a breast MRI. So exam time, simple, minimal motion artifacts, because it's a quick study. Whenever we prolong a study, motion artifacts are increased. And cost, time tolerance, and access. In that case, if we are looking at the future of breast imaging in 10 to 15 years, it's upcoming, it's there in all the conferences across the world. So this is what we are looking at. I will just wind up. Thank you very much. To conclude, I would say that despite our affection for fatty breasts, our real challenge lies in to counter the problems, the dangers of the dense breast. And for that, we have to reimagine breast in 3 dimensions. Thank you very much.
Thank you, Dr. Isha, for wonderful talk on staying in dense breast tissue. Do you have any questions from audience regarding this from Dr. Isha?
रोज अगली है
CTV लो के भी लो MS के ऊपर परफॉर्म होता है. डोज इसके अंदर मैंने नहीं मेंशन की थी, तो मैं भूल भी गई कि क्या थी, बट इसकी आप देख लें कि एज कंपेयर टू नॉर्मल CT स्कैन, इसकी रेडिएशन जो डोज है दैट इज प्रीटी लेस. सो आई थिंक बहुत ज़्यादा कॉन्ट्रास्ट इसके अंदर यूज नहीं होता, जस्ट बिकॉज यू हैव टू फोकस ऑन द एनहांसिंग ऑफ द ब्रेस्ट. हमारा और कोई टारगेट नहीं है कि हमने कोई वेसल्स को देखना है या कुछ नहीं है.
Right, moving to our next presenter, who is Professor Dr. Shahzad Karim Bhatti. Professor Dr. Shahzad Karim Bhatti graduated from King Edward Medical College, did MCPS and FCPS in radiology from CPSP, and MSc in pain management from Lahore University, Islamabad. He has done his fellowship USA. He is an interventional radiologist and pain management specialist working as associate professor and actually in King Edward Medical University, Lahore. He is leading co-ablation technique used for multiple cancers in the hospital, Lahore. So I would request Professor Dr. Ezad Bin Badi to come on the podium and talk about the co-ablation technique, which is the new innovation we have started last year.
इसके बाद आपको स्ट्रीमिंग का सब ठीक है जस्ट इसके बाद
I hope all of you can hear me. Welcome to King Albert Medical College, especially वो लोग जो शहर से बाहर से हैं, कितने लोग हैं?
तो सारे बाहर से हैं, from Peshawar, Faisalabad, Islamabad.
Welcome to Lahore, to the beautiful city. जैसे मुझे याद आ रहा है, शहर में हम आपके चर्ची देख के खाते हैं, यहाँ पे बड़ी लड़ाई नहीं। I hope white fly that is very nearby here. So आप सारे आए और बच्चे से enjoy करेंगे, enjoy Lahore. अब तो बसंत की आमद है, अब तो तैयारियां लोग बसंत की भी शुरू हो गई। अब beginning of festival for Lahore. And welcome to King Albert Medical University. I've been a student here. It's an honor for me to start serving here as a part of the faculty as well. The topic I'm about to talk today is a different one. The latest thing that is being done in this part of the world, the first time ever the coagulation technique is being used here. We have done 28 cases till now, and few of them are for the best. I'm going to discuss the basics of it, or with the practical experience what we have done. So coagulation, the word coagulation means combined ablation, means the combination of cryoablation and thermal ablation. Minimally invasive technique for the treatment of the tumor destruction. It's an image-guided approach using ultrasound and CT scan. That is why we were involved as a radiologist. But we cannot do all these procedures without the help of surgery. I'm so grateful to Professor Ahmed Uzair Qureshi and Professor Abrar for their continuous support and the Department of Anesthesia for their continuous support with us as well. So it's basically a team effort that cannot be done alone. So cryotherapy has been a practice for centuries. In 1845, when James Arnold, a British doctor, performed a cryosurgery of fungating tumors with a site on big step. So he reported reduced tumor size and pain to the development of liquid air using the liquid carbon dioxide, ethyl chloride and methyl chloride and snow composed of solid carbon dioxide sticks minus 80 degrees. So in 1961, the Irving Cooper developed a machine that separated liquid nitrogen at minus 195 degrees through a partially insulated probe which allowed a controlled freezing of deep structures. So in trials currently there are two multi-center industry-sponsored trials utilizing liquid nitrogen cryoablation devices are evaluating the cryoablation primary treatment without surgical incision. That is without surgical incision for early stage, small, low risk, invasive breast cancer. So the cryoablation of small breast tumor in early stage breast cancer trial, the cryoablation of low risk small breast cancer trial. In 2021, Fine et al. Published a 3-year interim analysis results which demonstrated an ipsilateral breast tumor recurrence rate of 2.06%, 4 out of 194 patients, similar to that after breast conservation surgery. So these are new modalities coming up which are proven, but it needs a lot of improvement, a lot of study to be verified, them. So technical considerations क्या होती है? Cellular injury depends on 4 thermal parameters. Freezing rate क्या है? It will discuss. And lowest temperature कितना है? Whole time, the time held at the lowest temperature and the thawing rate, heating rate. So optimal technique क्या होगी? Fast freezing to low temperature, slow thawing to further to damage the cells, and repetition of the freeze thaw cycle. अब कितनी दफा इसको repeat करते हैं? कितने minutes के लिए? This all depends on the experience. This all depends on the type of the tumor, and this all depends upon the response of the patient, which you can see either on ultrasound or on the CT scan. Pre-procedure imaging क्या होगी? Up-to-date imaging is important to select क्या होगा? Appropriate type and number of cryoprobes. I'm going to see you the show you the cryoprobes कितनी है, कौन सी है, कैसी है, and determine the optimal cryoprobe approach. कैसे approach करते हैं, किस जगह पे select करेंगे, and then entry point and final placement. It all depends on किस जगह से enter होना है उस tumor के अंदर और कहाँ पे जाके probe को हमने part करना है. Ensure complete tubal ablation and avoid skin or chest wall or pectoralis muscle injuries. Because we can see that some breast tumors are very superficial, so we have to see minus temperature, say minus 195 degrees in breast necrosis, the skin necrosis not happen. So ये probe है, इसके आगे ये ice wall. So careful selection of type and number of cryoprobes. हम all depends कि आपके breast का या किसी भी tumor का size कितना है. उसके मुताबिक हम select करते हैं हमें एक probe use करना है कि दो probe use करना है, because this ice wall has a specific size. So and number of cryoprobes is necessary to ensure a heating temperature of minus 195 degrees in a tumor and margins. We have to look at the margin. देखो margin में रहे. The shape and size of the resulting ice wall is based on the cryoprobe type, type कौन सी है, needle का size कौन सा है, needle number in addition to the length of the freezing time. ये सब जरूरी है आपको मालूम होना कि probe की size कौन सा है, ice wall का size कितना है, freezing time हमें कितना रखना है. Ice wall size increases with freezing time and number of freeze-thaw cycles. So these are all those ice walls. अब हमारे पास मुख्तलिफ किस्म की प्रॉब्लम है, मुख्तलिफ किस्म की आइस बॉल है. So as per the shape of the tumor, size of the tumor, location of the tumor, we decide priorly हमें कौन सा probe use करना है, और उसके बाद हमें कौन सा ice balls पे बनेगा, उसकी कितनी margins होगा, और उसका हमें कितने margins रखने हैं. This all pre-procedural planning. Why collaboration? It combines the benefit of freezing and heating, the better tumor control and less recurrence, and safe for high risk and inoperable patients. Mechanism of action क्या होगा? Freezing, ice crystals, the cell death, thermal ablation, heating, the protein denaturation and necrosis. Sequential cycles improve the efficacy. So we starting more than one cycle. Equipment इस्तेमाल क्या करती है? Coagulation machine integrates cryo and thermal ablation, probe inserted in the image guidance, strictly under image guidance. हम 1 इंच भी नहीं बुलाते जब तक हमारे पास image guidance का evidence नहीं होता है, and we record that evidence and we always keep comparing with the previous images. Real-time monitoring ensures accuracy because you are actually seeing the patient, you are actually seeing the image, you are actually seeing the tumor, you are actually seeing the ice wall. Machine was this Hygia machine, a Chinese-made machine. 200 से ज़्यादा hospitals में इस्तेमाल हो रही है चाइना के अंदर. They have done more than 25,000 cases of this cryo or coagulation there in China. ये probe है, this salt is used. इसके आगे thermal area जिसके अंदर ये ice wall बनता है. ये tubing है जो हम इस machine से इसके साथ connect करते हैं. So we can attach 4 probes at one time depending on the size. We have done दो हम देखी हैं. ये हमारी अल्ट्रासाउंड मशीन है जिसको हम यूज करते हैं स्पेसिफिकली ब्रेस्ट के लिए, लेकिन ये सीटी स्कैन है जिसको हम यूज करते हैं लंग्स के लिए, लिवर के लिए और रेनल ट्यूमर्स के लिए. सो वी कंबाइन ऑल दी मोडेलिटीज. हम लिवर में अक्सर जो एंट्री होती है वो अल्ट्रासाउंड गाइडेंस लेते हैं, देन वी कीप दी मॉनिटरिंग विद दिस. So we have to engage CT scan and ultrasound at one time. Lekin breast mostly we do it with the ultrasound guidance. So temperature ranges are cryoablation minus 196 degrees, minus 196 degrees. and the thermal ablation is plus 85 degrees. Single probe ये दोनों काम करते हैं. गैस कौन सी यूज होती है? लिक्विड नाइट्रोजन for coagulation and ethylene for heating. Indication: lung, breast, liver, kidney, soft tissues, pancreas, bones, prostate, thyroid, and adult cancer pains. We have our experience with the lung, breast, liver, and kidneys, and a tumor. We have done the rectal tumor. We have done recently, but successfully done. So मैंने तो दिखाया ये प्रोब है, ये इसका आइस बॉल है. ये जब हम किसी भी प्रोसीजर करने से पहले हम इस प्रोब को चेक करते हैं आइस बॉल बाहर बना के. This is the probe working, काम उसका हो रहा है कि नहीं, आइस बॉल बन रहा है कि नहीं बन रहा. उसके बाद फिर हम आगे काम करते हैं. So we have an app. मेरे हॉस्पिटल के अंदर हमने एक ऐप बनाई है which is KEMU Memo Collaboration Clinic app. इससे कोई भी पेशेंट अपनी बुकिंग करा सकता है before for the prior checkup. You have collaboration clinic in surgical tower. वो आप आके देख सकते हैं. Again grateful to उनकी वो स्किल लैब थी जो उन्होंने हमें दे दी और उसको मारकर जो मेरे हॉस्पिटल की कोई ऑपरेशन क्लिनिक के नाम से इस्तेमाल करते हैं. This is how it looks like. ये ऐप है. अच्छा हम पेशेंट सिलेक्शन कैसे करते हैं? We have an MDT meeting consisting of all these specialists: general surgery, medicine, anesthesia, oncology, radiology, and all बाकी administration के लोग होते हैं. So everybody has to sign the document जिसमें patient selection होती है. MDT के अंदर ये decide करना है कि इसकी surgery होनी है, इसकी हमने oncology करनी है या इसकी हमने coagulation करनी है. Then we have certain selection criteria. यहाँ पे चूंकि फर्स्ट टाइम ये काम हुआ था इसलिए इसकी गाइडलाइंस भी बनी. उसके बाद हमने सिलेक्शन क्राइटेरिया भी रखे तमाम चीजों के लिए. So for breast, we just talk about breast. Age mostly less more than 60 years, a single lesion, not fit for surgery and chemo. जिसमें HR, ER, PR positive, HER2 negative, no mets, no insulin lymph nodes. So we have a narrow window of selection. वर्कअप क्या होगा? बायोप्सी हुई हो, फार्मास्यूटिकल्स का पता हो, सीबीसी हुई हो, एलएफटी, आरएफटी, पीटीए, पीटी, आईएनआर हो, सीटी क्या विद कंट्रास्ट, इको एससीटी. पेशेंट इज नॉट एनेस्थेटाइज्ड. हम ये नहीं देते. मॉनिटर्ड एनेस्थीसिया होता है किसी प्रॉब्लम के पेशेंट ताकि एंजाइटी ना हो. इसके अलावा और कुछ नहीं पड़ती. तो प्री प्रोसीजर इवैल्यूएशन इट्स ऑल बी डिटेल्डली हम उसको इवैल्यूएट करते हैं पेशेंट को. तो उसके बाद ये पूरा एक फॉर्म है जो फिर होता है. Then indications क्या कि मैंने बताया था liver, lung, breast, renal palliative pain management के लिए यूज करते हैं. फिर हम informed consent देते हैं. Assessment, coagulation profile check, and anesthesia plan. Everything is done before the procedure. It's been meticulously planned. Antibiotic prophylaxis, IV access, mark entry under image guidance. So patient positioning, image guidance with ultrasound, probe insertion into the tube, freezing heating cycle, and then post-procedure imaging. So probe की placement हम ऐसे करते हैं. It has to. This is a probe. It has to be placed just at the anterior border of the tumor. बल्कि 0.5 millimeter, 5 millimeter हम probe को आगे रखते हैं tumor से ताकि तो कोई area रह न जाए इसकी coverage. So intraoperative modifications क्या हो सकती हैं? Imaging guidance most commonly ultrasound for breast is using. During operation are identify tumor location. Skin से कितना दूर है, vasculature कितना है, chest wall, पेक्टोरल मसल से कितना दूर है, size क्या है, morphology क्या है, margins कितने हैं. You have to consider all of them. Confirm appropriate prior probe placement within the tumor and monitor site prior severe. Ice wall plus tumor expansion to ensure complete tumor and margin coverage. The probe should be placed through the center of the tumor. Tumor के center में हम इसको रखेंगे and then we do the procedure. So post procedure में we monitor vitals, pain management, patient sent to surgical ward for 24 hours. 24 घंटे बाद हमारे पास आता है, उसको assess करके oncology को देखते हैं, then they can send them home. Follow up everything after 24 to 48 hours and follow up after 1 month to oncology. Oncology वाले को clear करते हैं patient को, फिर हम उनको आगे डिटेल में बताते हैं आगे क्या आपने करना है. So very rare complications, bleeding, infection, pneumothorax, damage to surrounding structures on crash are very rare. Prognosis, local tumor control is 85, more than 85% this study. Minimal complications, reduced recurrence risk versus single technique, improved quality of life. Patient हमारे पास आते हैं तो कोई पेन नहीं है, कोई उसके बाद problem and we keep asking and keep calling the patient. Pressure -192 is we keep monitoring it. हमें टाइम साथ मॉनिटर करते रहते हैं कितनी देर का साइकिल हमने करना है. It can be up to 3 to 15 minutes depending upon the condition of the patient and location of the tumor, size of the tumor. This is how the graph looks like. Take a positive 84.2 degree centigrade. ये हम 1 मिनट के आमतौर पर इसको खाएं या हीटिंग करते हैं. फिर ये we can keep looking at the graph कि टेम्परेचर कितना गया, उसके बाद डाउन कितना हुआ, ये हमने बीच में टाइम दिया, उसके बाद दोबारा we see how much the temperature we want to attain and for how much time. This is formation of the ice wall. ये ice wall अल्ट्रासाउंड पे इस तरह देखते हैं. ये बिल्कुल जैसे स्टोन की तरह देखते हैं. इसके नीचे में वो कुछ नजर नहीं आता. So you have to plan before it. इसको आपने कितनी देर यहाँ पे रखना है. जैसे टाइम बढ़ता जाएगा, ice wall का साइज बढ़ता जाएगा. Few of the patients in the end. अब ये this is how we see it. The mammogram shows a solitary lesion, speculated margins. CT shows again solitary lesion, confirmed. Then we do the CT CAT to see any other metastasis. And then this is how it was done under ultrasound. The probe was parked at the end. We had the ice wall formed. We keep looking at the procedure. Then this is a pre-procedure and post-procedure. Pre-procedure, we can see the tumor, and post-procedure area, this tumor was not seen on the ultrasound. Just a 60-minute procedure. No need of anesthesia, no need of any cut, no need of any general anesthesia. Just monitored anesthesia. Another case, see the tumor, it was approached, and then we can see the pre-procedure images and post-procedure images. Same patient. 1 घंटा, सवा घंटा, that's it. Patient goes back to the ward and then to the home next day. The latest case we have 3-4 दिन पहले किया. This is the tumor, this is the probe, and then this is the post-procedure images. लेकिन एक चीज थी जो हमें हौसला इसमें हमारा काफी ज्यादा बढ़ा है कि आप जो काम कर रहे हैं उसकी एफिकेसी कितनी है. ये पेशेंट की हमने कुछ अर्सा करें, 1.5 महीना पहले किया. हमने अपनी तरफ से वेल सारा कुछ करके फिर हम मॉनिटर ऐसे करते हैं कि 1 महीने बाद उसको बुला के सीटी करते हैं. इस पेशेंट का कंट्रास्ट एनहांस करने एमआर किया था. एमआर के अंदर सिर्फ रेजिडुअल चेंजेस आई हैं. उसके बाद हमें इन शॉर्ट कि हमारे ख्याल में देयर वाज नो ट्यूमर इन इट. बट शी वेंट टू सम अदर प्लेस जहां उसके एमआर को मैं दोबारा इवैल्यूएट किया. क्योंकि हमारा ख्याल है कि इसकी पेरिफेरल एनहांसमेंट हुई है, सो उसके ट्यूमर हो सकता है. Then she went to some other surgeon, जो हमारे सर्जन में से किसी के पास नहीं गई. उन्हें जाकर इसकी रेडिकल मिस्टेक्टमी कर. After radical mastectomy, the patient sample was tried to be for the histopathology, and this is histopathology. So no residual tumor seen. It's very encouraging. This patient की the radical mastectomy में होगी. The patient was sent to the lab for the histopathology, and histopathology is proved negative. तो हमारे लिए हौसला बढ़ा के अगर आप ये काम करें, keep working on it, then you can have this result. So this is more, I think that this is more encouraging to all of us, all of those who are doing surgery, all of them doing the oncology, and all of us who are doing this purpose as well. So this is our oncology team, the therapy. So conclusion is that cryoablation or coablation combines 2 proven techniques. Safe and effective with minimal complications. Coagulation under image guidance is a safe, minimally invasive technique. An excellent option for non-surgical candidates, but we still need more cases to prove the efficacy of the procedure. Thank you.
My name is Dr. Akida Shirazi. I am the resident breast surgeon. My question is, we encounter a lot of patients who after chemotherapy have a complete response. So my question is for the Dr. Isha. There are a lot of patients which we encounter which do not have a clipping pre-chemo, and post-chemo they have a complete response. I want to know if there is any novel investigation which we can go for to pick up the area of the primary lesion where there is no clipping pre-chemo.
Unfortunately, there is not, but what we can do is that we can perform a breast MRI. Mild enhancement can be detected on a breast MRI because breast MRI is very sensitive. It is going to pick up anything and everything. Same goes for contrast enhanced mammography. It will pick up all benign lesions which are vascular. It picks up inflammation. It picks up post-surgical changes. So we have seen patients in which clipping was not done. Breast MRI could delineate the area of architectural distortion, it would show some enhancement, but then again, we cannot be sure, and it would be a risk to, perform any lumpectomy in those patients. So totally, the decision then would depend on the surgeon, how confident he or she is. You have to then compare it with previous mammograms to see what the size of the lesion was. So this will have to go in a holistic way, and you have to be in touch with your radiologist. And this is how it's going to be, because it gets very very difficult once, because we also encounter these patients. मेरे पास भी आते हैं to wire them or to localize these lesions, and it gets really hard. Sometimes on an ultrasound, yes, you can look at an area of architectural asymmetry, and then you can, wire करवा दें उस patient को if the radiologist is able to look at that. Because palpate तो शायद बिल्कुल भी नहीं होगा post chemotherapy, but maybe the radiologist would be able to see something. So that's the only way.
Any further question from our?
Well, I want to ask Professor Shehzad. I'm Dr. Somar. I'm working as Associate Professor over here. My question is, you said we were using four probes in a single cannulas in a single tumor. And what I gauged from your discussion, we have to pass the probe through the center of the tumor. In which condition you used four probes?
I said we can use four probes. We have never used four probes. We can use four probes. We have used two probes, but only the liver tumor. Because the size of the tumor is more than 4 centimeters, then we have to see the size of the eye swab. So we have to cover the margin. So we use two probes till now. But machine has requested using four probes.
As this procedure is still in infancy, how many cycles can we give for a single tumor till it disappears, or how many cycles in a single session?
3 to 5.
Or if it doesn't disappear, then you have to ask her to come again, or?
We always ask her or him to come again. We evaluate the patient and we do the CT scan after 1 month or an MRI to see the confirmation of the tumor, because we do it always contrast enhanced MR or CT. Then we always consult our oncology fellows that what should we be doing with the patient after the follow-up. So 1 month, 3 months, and 6 months, they are being followed.
No, I'm just asking if it doesn't disappear in us. If still there, while you are doing the session after 3 to 5 cycles.
But with this, 5 cycles are maximum is done, and mostly in 20.
Then we refer back to
Yes, yes. They have disappeared.
So मेरे ख्याल अभी तक तो ऐसा नहीं
नहीं हुआ, अभी तक नहीं हुआ.
Breast वाला concern, this is something, since this is something new. And Shehzad sir has been doing a wonderful job in this. We've been being very careful with starting a new process that can actually file back. So what we have done from literature is cryoablation in breast surgery and coagulation in breast surgery has been done only in cases in very good studies in Japan. But these are the patients who are more than 70 years of age. They were not a candidate for breast surgery, or they did not want to have a surgery. So many of the Japanese did not want to have surgery and they opted for this procedure. So we exactly took up those guidelines, and now we only operate. The number is less because they are very selective. These are all the patients who are not candidate for surgery, who have some kind of a comorbidity, or they do not want to get this themselves operated. So उनको हम बता के ये चीज़ अब start कर रहे हैं, और उनको जो evidence आ रहा है वो evidence is good. Still it is just in infancy. Slowly, gradually going up. जो liver है उसके number patients ज़्यादा हैं, millions ज़्यादा हैं, उनको follow करना आसान है. वैसे की younger patients हैं, और उन younger patients के साथ disease का progress की वजह से है. लेकिन ये कि we are working on it, and inshallah very soon we have started preparing some ideas. So आप समझ रही अगर आप लोगों को कोई क्वेश्चन पूछना है तो सबसे पहले
मार्जिन का क्या करें?
किसका अभी फिलहाल तो बताया ना कि अब हमने ये वो पेशेंट्स हैं जिनका हमने किया कि इनको टाइप so the tumor is gone, right? So there is no tissue left there. The only thing we can do is we just will have to follow up on a long term कि वहाँ पे चीज बनती है निकलती है. These are patients who are not candidate for surgery anyway. So we're helping them to remove those tumors from there. They are not there. ये जो
सर अपने क्राइटेरिया में ये रखा हुआ है कि मतलब ये कोमोर्बिड है, नॉट एलिजिबल फॉर
हाँ, हाँ।
सर्जरी या ER पॉजिटिव
आपको बताऊं हमने we have tried something like पहले जब स्टार्ट हुआ ये तो शहजाद साहब बेहतर बता सकते हैं.
जी मैं बताता हूँ
हाँ, बताइए.
उसमें ऐसे है कि मार्जिन का बहुत अच्छा आपने सवाल पूछा प्लानिंग होती है प्रोसीजर करने से पहले वो देखी है अब मार्जिन 5 मिलीमीटर और ज़्यादातर मार्जिन एक्स्ट्रा रखते हैं नॉर्मल टिश्यू लेते हैं साथ में 5 मिलीमीटर ऑल अराउंड हम लोग प्रोब का सिलेक्शन करते हैं कि प्रोब का साइज क्या होगा प्रोब की जो आइस पर बनेगी उसका साइज क्या होगा उसकी शेप क्या होगी कुछ ऑब्लॉन्ग शेप है कुछ बिल्कुल राउंडेड है तो दिस वी डिसाइड हमें ट्यूमर के मार्जिन चाइना के अंदर उन्होंने दूसरा काम शुरू किया बिकॉज वी आर स्ट्रिक्टली रिलेटेड चाइना के अंदर में यंग पेशेंट के लिए फॉर कॉस्मेटिक रीजंस जो फाइब्रोएडिनोमा जो उन्होंने इसकी भी कोएबिलिटी शुरू की है दिस इज वेरी सक्सेसफुल इसमें लेकिन यहाँ पे जो कि हमारे पास इट्स एक्सपेंसिव प्रोसीजर $5,500 की एक प्रोब है सो वी आर स्ट्रिक्टली एडहेरेंट टू द कैंसर पेशेंट्स बाकी सिलेक्शन वही जैसे सर ने बताया वो एमपीटी का जो मैंने आपसे देखा खास तौर पे किया कि दैट इज बीइंग सिलेक्टेड बाय दोस ऑल 7-8 कंसल्टेंट्स एवरी वेडनेसडे वी हैव एन एमपीटी उसके बगैर कोई पेशेंट नहीं करते जब तक हमें जैसे सर डिसाइड करते हैं किसी सर्जरी होनी चाहिए या ऑन्कोलॉजी होनी चाहिए और यहाँ में जो हार्मोनल पैरामीटर्स हैं रिस्ट्रिक्टिव फॉर देम एज वेल सो पेशेंट इज सिलेक्टेड इसलिए हम रिलेटिवली कम पेशेंट्स बिकॉज हम उनको सिलेक्ट अंडर स्ट्रिक्ट सर्वेलेंस करते हैं
So MDT तक हाँ जी MDT तक इस वक्त तक हमने 150 केसेस प्रोसेस करके वहाँ पे पहुँचे हैं और उसके बीच में से ये 26 पेशेंट्स होते हैं जो वेरी केयरफुल विद द पेशेंट सिलेक्शन और हम ग्रेजुअली उसका साइज ऑफ ट्यूमर और साइट ऑफ ट्यूमर उसको थोड़ा सा बढ़ा रहे हैं ग्रेजुअली दैट विल बी
आपकी जो पेशेंट सिलेक्शन है मैंने जो मुझे समझ आई है वो है ल्यूमिनल की यही पेशेंट्स हैं और अगर हम ये कहें कि पेशेंट ठीक है ओल्ड एज भी है तो ल्यूमिनल ये जो पेशेंट है उसको तो वैसे भी कीमोथेरेपी से कोई खास बेनिफिट नहीं होना इन एज सो दैट आई थिंक दैट इज आल्सो इन योर माइंड व्हेन यू आर सिलेक्टिंग द पेशेंट क्योंकि या तो फिर उनको ऑन्कोटाइप डीएक्स करवाना को देखें कि हाँ उसको कितना परसेंट चांस है उसके अंदर तो द पेशेंट सिलेक्शन आपकी बात मैं इनको बस एंडोर्स ही करना था कि ये इंपॉर्टेंट है कि आपने कौन सा पेशेंट सेलेक्ट किया है क्योंकि डजंट मैटर कि उनके मार्जिन्स पे पॉजिटिव अगर रह भी जाते हैं तो पेशेंट इज नॉट फिट फॉर सर्जरी एनी डे सो इट डज नॉट मैटर एक सवाल डॉक्टर शहजाद आपसे ये है कि हाउ डू वी फॉलो दिस अप एंड व्हाट डू वी सी वंस वी परफॉर्म अ सीटी स्कैन ऑफ दिस पेशेंट लेटर ऑन
we follow usually after 1 month हम एक कंट्रास्ट एनालिसिस सीटी करते हैं और एमआर करते हैं इसी भी पुराने से कंपेयर करके हम उसकी जो एनहांसमेंट है पैटर्न में आंसर वो देखते हैं
ठीक है दिस इज फॉर लिवर और ब्रेस्ट
फॉर ऑल
फॉर एवरीवन we don't have a tissue left with us with the cryoablation जो हम कर रहे हैं उसके बाद हमारे पास टिश्यू तो कोई भी नहीं है तो we will be just following patient on imaging
yes
for residual disease or recurrence
yes
okay thank you
हमने अब ये किया कि जो पेशेंट की उनकी बायोप्सी भी की है जो रेजिडुअल टिश्यू था जहाँ पे हमें था कुछ सिस्टिक चेंजेस आए हम कुछ दिन पहले हमने उनकी बायोप्सी भी की है we sent that patient the biopsy to the for the lab reports so we are always trying to do everything we can do to see the recurrence ताकि इसके जो उसका अंदाजा होता है कि जो अभी आपको मैंने बताया रेडिकल मस्टेक्टमी हमारे प्लान में नहीं थी वो किसी और जगह पे गए उन्होंने जाकर उनको लगा कि इसके रेजोल्यूशन अभी रेजिडुअल डिजीज है उन्होंने किसी और सर्जन के पास गए मस्ट हैव नॉट कम टू डॉक्टर जाहिर उनको पता नहीं होगा रेडिकल मस्टेक्टमी कर दी उन पेशेंट ने आकर हमें फीडबैक दी कि हमारी तो ऑपरेशन हो गया तो अगर पेशेंट जो भी है उसकी रिजल्ट हो तो दैट वाज द रिपोर्ट वी केम दैट वाज नो रेजिडुअल डिजीज तो इट वाज एनकरेजिंग फॉर अस
So any axillary staging in the form of surgical axillary staging in the form of sentinel or axillary dissection?
Sir.
Thank you so much. So axilla के लिए हम वही प्रैक्टिस कर रहे हैं जो पहले प्रैक्टिस कर रहे हैं सो एक्सेला अगर नेगेटिव है तो उसकी सेंटिनल होगी, तो पहले क्रायोलेशन हो जाएगी और फिर सेंटिनल का। अगर उसकी एक्सेला की एलएलएस से एलएनडी बनती है तो वो वैसे ही चलती है। सो सर्जिकल प्रोसेस जो पार्ट है जो इज नॉट बीइंग टेकन अप एट दिस। सो स्टेजिंग में जब एमडीटी में आता है तो उस पेशेंट के सबकी तरफ से अल्ट्रासाउंड हुआ है एक्सेला का, अगर उसके अंदर कोई सस्पिशन नोट है तो उसकी एफएनएससी हुई ही है, उसकी बेस के ऊपर डिसीजन होता है। सो वी ओनली स्ट्रिक्टली फॉलोइंग दी गाइडलाइंस माइनस जो पार्ट है जिसको हमने कट लगा के निकालना था उसको हम प्रोब लगा के चला। सो
उसके अंदर ये है कि एक्सेला का पॉजिटिव है तो फिर वो पेशेंट आपकी इस क्रायोलेशन के अंदर
नहीं
वो नहीं
नहीं
आएगा।
आएगा
नहीं,
वो
वो
पेशेंट
पहले सारा कुछ चेक करके फिर आता है। अगर एक्सेला पॉजिटिव है देन नो इट इज नॉट।
नहीं अर्ली डिटेक्शन के अलावा आप इस तरह सोचें ना, ये वो पेशेंट है जो हम ले रहे हैं कि वो आर नॉट अ कैंडिडेट फॉर सर्जरी। सो वहाँ से थोड़ा सा हमें ये लिवरेज मिल जाती है कि पेशेंट से हम बात कर लेते हैं कि ये नई मोडालिटी है, इसके बीच में आप ऑपरेशन नहीं कराना चाहते, अगर आप एक नीडल के साथ इसको ऑपरेशन करवा लें, फ्री भी हो रहा है और इसमें हमारा ख्याल ये है कि लोकल कंट्रोल भी हम आपके ले लेंगे और उसके साथ एक्सेला तो फिर अगली स्टेप पे चल जाती है ना कि उसके इस तरह से, तो हम इस तरह से जाने की स्टिल अभी हमने सर से ये भी बात की है, मैं ये बात की है कि हम विल मूव दिस मशीन टू थिएटर्स एक्चुअली। सो थिएटर्स के बीच में जाने से ये होगा कि जितनी देर में सर क्रायोलेशन कर रहे होंगे उतनी देर में हम सेटलमेंट करके भिजवा देंगे, तो टाइम भी शॉर्ट हो जाएगा, एनेस्थीसिया भी एक हो जाएगा और मेरा ख्याल ये है कि दिस इज समथिंग कमिंग अप वेरी क्विकली।
Assalamualaikum, sir. My name is Dr. Amna Ashraf. I am a breast surgeon resident at Triple-Negative Hospital. I have two questions if I may ask. One is that comes to our mind when we discuss about cryogration, we're obviously leaving that necrotic tissue in the breast because we've done so many patients. Have you seen any complication there might be an abscess or mastitis or anything, and how to be treated?
Not yet, no. अभी तक नहीं. We keep following the patients. अभी तक ना liver के अंदर और mostly we have done liver cases on the breast and there's no evidence of any abscess or any complication.
And I'm sorry, I missed that part. How many patients exactly have we studied there to date?
28 patients, 9 of breast and 12 of liver.
So जो complication हम देख रहे हैं ना, जो complication वाला part हम देख रहे हैं वो देख रहे हैं सारे पेशेंट्स का, और जो particularly follow up long है जो ये मेरे साथ है वो breast surgery के सारी साथ चल रहा है. So दोनों चीज़. दूसरा आपका question जो था ना, देखिए size of tumor is still very small, 3 centimeter का tumor जब हम उसको पहले coagulate कर देते हैं, freeze कर देते हैं, coagulate कर देते हैं और उसके बाद वो सारे का सारा वहाँ dissolve है नहीं, so we are unable to find any local abscesses. हमारा पीछे ये बैकअप है, तो if anything such thing happen तो we would be happy immediately हम उसको grow करके चलें. तो इसलिए जो है ना वो दूसरा आपको मैं एक और बड़ी the term coagulation आप सर्च कीजिएगा नेट पे कि where and when it was turn point, तो आप खुद ही कीजिएगा क्योंकि that is an interesting thing to happen.
So I have another question too. You just said that for the sentinel biopsy, then the patient undergoes a surgical procedure afterwards. Is there any general anesthesia or local anesthesia? So when
हम उस प्रैक्टिस को नहीं चेंज कर रहे हैं, देखो ना स्टेप बाय स्टेप चलते हैं. इस टाइम के अंदर हमने कोएगुलेशन क्लिनिक बनाया है, कोएगुलेशन क्लिनिक के बीच में वो अंडर सेडेशन अपना प्रोसीजर करा के फ्री होता है, फिर उसके बाद हम उसको अपने वार्ड में शिफ्ट करवा लेते हैं और उसका सारा काम कर लेते हैं. वही चीज़ मैं कह रहा हूँ कि हम हैव सीन कि ये डुएबल है. इस डुएबल होने के बाद अब हम एक्सिला की स्टेजिंग को सेम सेशन में करना चाह रहे हैं, पहले हम 2 अलग सेशन.
we're doing the surgery anyway, so वो फिर
नहीं वो GA नहीं है, जो sedation में हो रहा है.
It's not general surgery in any way. It's not general surgery in any way. जो patient अभी तक हमने किया है, अभी तक general surgery की जरूरत नहीं पड़ी है. जिस और सर जो कह रहे हैं हमने assumptions की हुई है कि अगर ऐसा हो हम ये भी कर सकते हैं. So that is why we are more careful in selection of the patient कि उनको बाद में surgery की जरूरत ना पड़े.
क्योंकि मतलब as we go on, so we have been seeing a lot of studies where their imaging center boxes already. Already, I think both patients will be the best candidates to the center and community, but we will go the booster. But like,
Next step.
thank you very much. Thank you.
Thank you, everybody. So is this again, I just want to add for the breast residents regarding they were so enthusiastic for the co-patient. Actually, काम सर जैसे डिस्कस किया कि क्रॉस ट्रायल, आइस ट्रायल और अमेरिकन ट्रायल जापानी स्टडीज पे पहले ही हो रहा है और हर ट्रायल के अंदर देयर आर फर्दर दे हैव लिमिटेशंस वन लाइक क्रॉस ट्रायल के अंदर सेंटिनल लेपर बायोप्सी वाज द मैंडेटरी. सो जस्ट लाइक जो इन्होंने क्वेश्चन किया कि वहाँ पे आप पोस्ट प्रोसीजर पे बायोप्सीज करते हैं कि नहीं, तो जैपनीज आर डूइंग दिस कि वो रिंग बायोप्सीज करते हैं. क्रॉस ट्रायल हर आप ये तीन चार ट्रायल्स हैं इसके और रीड कीजिएगा तो इनसे कोरिलेशन की जब से ये स्टार्ट हुई तो हर एक के अंदर कुछ ना कुछ डिफरेंट है. फ्रॉस्ट के अंदर सेंटिनल इज मस्ट, आइस के अंदर सेंटिनल इज नॉट मस्ट. उसी तरह उनकी जो लिमिटेशंस है आगे डिस्कस होती है. ठीक है. सो few online questions have also arise. So Dr. Sadia has discussed so one of the many diagnostic modalities when with the routine memo is inconclusive. What is the best diagnostic modality we should choose? NBI, MRI, CT, contrast enhanced memo. So I think it's the general question. I think she asked from Isha. ये कह रही है कि रूटीन तो इनकम्प्लीसिव हो गई है तो हम तीन सब में से कोई एक ना एक क्यों ना चूज कर लें. रूटीन मेमो. या
अच्छा वर्ल्ड ओवर जो अभी फर्दर मोडालिटीज जो आ रही हैं उसके अंदर मैंने ये देखा है कि ब्रेस्ट एमआरआई is being replaced by contrast enhanced mammo. Breast MRI is being replaced by contrast enhanced mammo in many centers of the world. It is cheaper, it takes lesser time. Effective as a breast MRI. So अगर किसी चीज में invest करना है तो I think that would be contrast enhanced mammography rather than a breast MRI.
So there is another question online from the YouTube from Dr. Shehzad.
I was suggesting that with this America risk stratification, taking the age into account, cost and all the factors and availability of resources, why not going for those females with a strong family history and dense breast, aggregated MRI जैसे कि कहा we can go ahead with it, predict them, good screening too, but then थोड़ी सी variability आ जाएगी. Avoiding radiation, avoiding any radiation, young female would be a good candidate for aggregated MRI. While in the later age group, MRI.
One more question from Dr. Shehzad, because this program is going online from the YouTube as well. So Dr. Mohammad Khalid Mirza has asked Dr. Shehzad why the government officials are sensitizing cryoablation as breakthrough in cancer management while we are using it in the patient not fit for surgery or chemotherapy. So they are just twisting the advertisement.
It is not the cryoablation, it's the coablation. It's never been done before. It's the cryoablation is done long time, but coablation literally never ever before. So we are combining these two techniques which have got very good results. So we have got combining these two. So this is the first time ever here. That is, I think, that is why they are advertising it. So the cryo and plus thermal, both of them at one time.
The question was mainly was that we are projecting like a medical therapy for every type of cancer, but we as a practitioners or a doctor shouldn't ask the government that we are doing only for a limited selected number of patients, just like we're discussing not fit for surgery like that.
Yes, we are working on it. We are conveying the messages to everyone that this is our that we are going on the media as well. This is for the state one viewers. Well, as government, I cannot speak about.
Okay, so we conclude our first session regarding, so those who joined late, this session we started at 9 was regarding early detection and imaging advances. There was a wonderful presentation from Dr. Isha regarding BPT and contrast enhanced mammography. and from Dr. Majmi in screening in denser breast and novel screening modalities, and then Professor Dr. Shehzad Bhatti regarding the latest innovative technique of the breast coagulation used in Mayo Hospital Hall. Our last presenter could not make it, Dr. Ahmed Zaid due to some health emergency in his home. So we are concluding this section, and I request all my requested teachers and delegates sitting on the front line to come over the stage and for award distributions. Any question left for this session? We can ask anybody. Okay. We request Professor Dr. Ahmed Zaid, who is heading our breast cancer surgery department. He is Professor of Surgery in the King Edward Medical University and as well as the supervisor of breast cancer fellowship program in King Edward University. And I now request Associate Professor Dr. Somal Malik to kindly join, and Dr. Tahir Rashid, kindly you can join as well. सब लोग याद है फ्रंट रोज आप जो ऑडियंस आप आ जाएंगे. So our first presentation was from Dr. Mahjubin Masood. I request Dr. Ahmed Zaid to present the thing here to Professor Dr. Mahjubin Masood. So our next presentation was from Dr. Isha Tahir regarding the digital breast tomosynthesis and contrast enhanced mammography. The third presentation was from Professor Dr. Shehzad Bhatti, and it was regarding the breast coagulation in the Mayo Hospital. So thank you all. This is our session. So we are now moving over to our next session, and it would be having two presentations and followed with a tea. Okay, so you have to wait for a little further minutes for a tea break. So we start. I will be again moderating this session. This is session about the pathology and molecular characterization. Okay. So we request Dr. Fatma Rumani to come over the podium. Dr. Fatma Rumani is a consultant histopathologist at Chuktai Institute of Pathology, bringing over 5 years of postgraduate experience to her role. She has previously served as a locum consultant at Bradford Royal Infirmary Hospital in the UK, where she led the breast histopathology services. Dr. Fatma has a strong academic and research interest in breast pathology, with several publications and ongoing research projects in her area of expert. She also contributes to global pathology community as an author of pathology outlines and play an active role in the training and mentorship of postgraduate residents at our institutes. I welcome Dr. Fatma Rumani.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. And it is indeed a pleasure to speak on such a prestigious platform and to learn so much from my fellow colleagues. Okay, so the topic that was assigned to me was biomarkers and the molecular subtypes of the breast cancer beyond morphology, pathology that drives therapy. So no more morphology alone. So breast cancer is no longer defined by the morphology alone. Histology defines tumor grade, tumor type, but biology determines the behavior and the treatment. And other prognostic factors like lymphovascular invasion, periural invasion comment upon the margin status. But modern breast pathology is not only about morphology, it is about morphology and immunohistochemistry as well as the molecular data. What does the biomarkers guide? It guides that whether the patient would get benefit from endocrine therapy, anti-HER2 therapy, chemotherapy, or immunotherapy. As you can see that there are different types this might be difficult for you, but these are basically different different morphological subtypes of the breast cancer. But the behavior will depend upon the expression of the biomarkers and what molecular subtype these tumor will fall into. So what are the core biomarkers in the routine practice as per TASCO and the CAP guidelines for my residents? These are basically four biomarkers that we routinely practice in the breast cancer patients. These are estrogen receptors, that is ER, progesterone receptor, that is PR, HER2-neu, and Ki67. So these are the four core biomarkers that has to be reported in a patient of breast cancer report. So what are these biomarkers? What are the methods of identification, and what is the clinical significance? So the estrogen receptors, that is the ER, is detected by immunohistochemistry, and it predicts the response to the hormonal therapy. The progesterone receptors is also detected by immunohistochemistry, and that adds a prognostic value. HER2-neu, it is picked not only by immunohistochemistry but also by FISH when required for equivocal cases, and that tells whether the patient will get benefit from the anti-HER2 therapy. And the Ki67 index is also picked on immunohistochemistry, and that correlates with the tumor growth rate. So these were the four biomarkers that I have told you that should be reported in a patient of breast cancer. Next is the molecular subtypes. So depending upon expression of these biomarkers, a molecular classification was formulated to see which kind of tumor will be assessed as per the targeted therapy. So there are a total of four broad classification, that is luminal A, luminal B, HER2 enriched, and triple-negative breast cancer. So what is luminal A? In the luminal A class, ER will be strong positive, PR will be strong positive, HER2 will be negative, and Ki67 index will be low. And this class has got the best prognosis. Next is luminal B, that is ER will be strong positive, PR is low as compared to luminal class A, HER2 can be positive, can be negative, and it has got a high Ki67 index, and it has got a more aggressive course as compared to the luminal A. Next is HER2 enriched. As the name indicates, ER, PR will be negative, and the tumor will only express HER2-neu, and the patient will get anti-HER2 therapy. And the last is triple-negative breast cancer. As the name indicates, it will be triple-negative for all of the biomarkers, that is ER negative, PR negative, and HER2 negative, and it carries a very aggressive course, and there is no standard targeted therapy. So this was the basic knowledge about the biomarkers and the molecular classification of the breast cancer. As we all know that there are rapid advancement not only in the subspecialty like surgery and radiology, but also in the histopathology part of the breast cancer. So considering the time limitation, I will only highlight those updates or those changes which are clinically relevant. So let's start with it. ER low positive tumors. So when I started my residency in 2015, we just used to see the slide. There is a breast cancer. We used to apply the essential biomarkers, that is ER, PR, HER2, and Ki. And if we used to do the scoring, that is the Allred scoring, I'm sure the fellow breast surgeons would be aware of it. So we used to score the ER depending upon the Allred score. If it used to be positive, we will give a positive report. If it's negative, we will give a negative report. But this is the change, recent change. So what are the ER low positive tumors and why they should be reported? So ASCO and CAP guidelines has formally introduced the term ER low positive breast tumors in 2020. So what are these tumors? So 1 to 10, so if the 1 to 10% of the tumor cells are ER positive on IHC only, it will be labeled as ER low positive tumors. So this is a distinct category. We should think that why they have formulated this category. This is because this is a biologically gray zone. Apparently they are ER positive, but they are not going to behave like conventional ER positive tumors. So they are not truly luminal, like they do not fall under the category of the luminal A or luminal B, and they are biologically heterogeneous. They are often high grade, they have a high Ki67 index and a low PR, and the molecular profile overlaps with the ER negative disease. The main thing is that these tumors have a limited benefit from the endocrine therapy, and the chemo response is almost similar to triple-negative breast cancer. So this is a simple diagram to explain what I have told you. So if the tumor cells, they are like equal to more than 10% of the tumor cells are ER positive, we will give it a category of luminal A or luminal B. So they are luminal biologically likely, and there is a high chance that they will respond well to the endocrine treatment. If the tumor cells are less than 1%, like technically they are negative, they will be called ER negative and they will be managed as triple-negative breast cancer. So now this gray area falls, that is the tumor cells that are 1 to 10% of the tumor cells which are ER positive, they will be labeled as ER low positive. So they are not going to behave well to the endocrine treatment, but they might get benefit from the chemotherapy. So how should we report it? So these are the updates in the pathology, how the clinicians would know. So the recommended points that the ASCO and the CAP says that should be highlighted under our ER low positive report is that we should report the actual percentage of the nuclear positivity that would range between 1 to 10. For example, 5% of the tumor cells are positive for ER. So we will give the exact percentage. We will label the tumor as ER low positive so the clinicians are alert that they are not going to treat the patient conventionally as ER positive tumors. And we should tell them whether the internal control was positive or negative, and it should be positive, so that we know that our test run is true. So this is an example of the suggested comment that the tumor is ER low positive, that is 5% of the nuclei are positive. Tumor in this category are biologically heterogeneous and may have a limited benefit from the endocrine therapy and may behave more like ER negative tumors. So this is something I think we should be highlighted considering a chance to speak on such specialized platform. Next low is HER2 low breast cancer. So this is a major recent update. So the HER2 low breast cancer defined as IHC +1 or +2 with negative-ish. So when I started my training, we used to call this tumor as HER2 negative only. So these tumors which were previously considered as negative was formally recognized in 2021 to 2022 following the Destiny Breast 4 trial, which showed that these tumors respond to novel HER2 targeted therapies. So previously there was a 2-tier scoring system. So there are basically 4 scores. So the IHC 0 is 0, +1, +2, and the +2 are the equivocal cases. For the equivocal cases, we send the sample for FISH studies. If it is negative, it is negative. If it's positive, then it's HER2 positive. And the HER2 +3 was considered as positive. So they were technically only 2-tier scoring system, that was HER2 negative and HER2 positive. But now after this trial, the ASCO and the CAP guidelines recommend reporting the HER2 low breast cancers because they say that they do well respond to the anti-HER2 therapy. So if on IHC HER2 is 0, it will be reported as 0. If it's +1 on IHC, +2 on IHC, and then it is sent to the FISH, and FISH comes out to be negative, then it is HER2 low. If it comes out to be positive, and additionally the IHC is +3, these are considered as HER2 positive tumors. I'm sure I'm not confused anyone, and it's clear. So next is triple-negative breast cancer. So this is a heterogeneous entity. So now there are 4 or 6 types of triple-negative breast cancer. There are more of the molecular types, that is the basal-like, immunomodulatory, luminal androgen receptors, mesenchymal-like. They are under research and they are actually a lot of molecular dependent. So right now we are not reporting it like this, but it is recommended that it should be reported in this way. The key biomarkers for the triple-negative breast cancers are PD-L1, that is the predictive markers, tumor-infiltrating lymphocytes, that is a prognostic biomarker. Higher the TILs, better the prognosis and immunotherapy response, and BRCA1-2 status, that is also a prognostic biomarker. So what is tumor microenvironment? So this is also a new prognostic tool. So TILs are now clinically relevant, especially importantly in the triple-negative breast cancer and HER2 +2 tumors, and it reflects host immune response. It predicts chemotherapy response, immunotherapy benefit, overall prognosis. So the good thing about the tumor-infiltrating lymphocyte is that it is reported on H&E and no extra cost is required, and it has got a high clinical value. Here I think it is important to tell that it is recommended but not mandatory to report TILs in a patient of breast cancer. Like in the melanomas, we report the TILs and we have to tell whether they are risk or non-risk. In the breast cancer patients, till now, it is recommended, but it is not mandatory. I'm sure when it will become mandatory, we'll start reporting the pills in the breast cancer patients as well. So the integrated diagnostic model should include not the morphology alone. So the morphology will tell the basic diagnosis. The biomarker assessment will be done upon expression of ER, PR, HER2, KI that guides the therapy. The molecular subtyping will be done on the expression of these biomarkers, that is luminal A, luminal B, HER2 enriched or triple negative breast cancer that defines the risk. And in the end, clinical decision will be made. So what are the take-home messages? Morphology is foundational but not diagnostic. Biomarkers defines treatment eligibility. Molecular classification explains the tumor behavior. ER low and HER2 low are emerging actionable entities, and strong pathology clinician communication is essential. So these are my recent key references where I took all the references. If anyone wants to take the picture, you might need to read about the two new laws, that is the low ER and low HER2 new. I would recommend please go through these articles. Thank you very much.
So any questions from Dr. Fatma regarding biomarker importance and any particularly low or ultra low?
I hope I have not confused everyone.
A question has a question from
My name is Professor. I'm PGR University. My question is, you said luminal A has a good prognosis, luminal B has a better prognosis. So I got it. I want to know, is there any basic reason why do they have good prognosis except that we can put that patient on chemotherapy later on or hormone therapy?
No, so there is like the hormone receptors will be positive. They've got a high. So this is the molecular basics. This is the biology. It's not the pathology that this is the basic biology that the patient will behave aggressively as compared to the luminal. You understand?
Okay. So this is the molecular basis.
Yeah.
Because sometimes we are taught that because the patient can be put on the hormonal therapy, so they have better prognosis. The patient cancer does not recur or something like this. This does not have to be used as the case. This basically means that the patient has luminal A, is less aggressive, luminal B is more aggressive. This is before hormonal therapy or before chemotherapy.
Yeah. Overall prognosis.
So, any other questions? Or I think we should move to our next presenter. So, initially it was planned by Dr. Suhail, but now Dr. Fatma will be joining us for this important note regarding liquid biopsies and spatial mapping. Dr. Fatma is a technical supervisor in molecular genetics. He has hold a PhD degree in molecular genetics and expertise in advanced molecular diagnostic technique and genetic analysis. He played a key role in ensuring the quality, accuracy, and reliability of molecular testing, especially in the breast cancer program. I welcome Dr. Fatma to kindly come on the podium and share her talk with us.
Assalamualaikum. Thank you for the kind introduction. Actually, the thing is that my field of specialty is genetics, so there are lots of things that I'm going to talk about genetics more rather than talk about the medical sciences. So it would be a different thing, but it's a different approach for the diagnostics of cancers. But I hope we have a good section on it. So the thing I will be talking about is liquid biopsies and spatial mapping. Dr. Fatma had done a really great and really comprehensive discussions on the diagnostics, that how we actually do it in the lab and how we classify our breast cancer morphologies on lab paper. Here I will talk about the technology that is actually not very prevalent in our detection system, which is the molecular diagnostic systems. We do talk about BRCA1 and BRCA2, But here we are talking about liquid biopsies because in BRCA1 and BRCA2 we only talk about blood. So this is how it is going to be. Like in biopsies you do it with tissues, but in here we are going to do it with the non-invasive methods. We will use blood, saliva, urine, even stool samples. We can use those samples to detect the breast cancer's morphological markers and do not only the screening but also the progressions analysis and also the therapeutic effects, that whether the therapy that the patient is using is effective and or not. So what happened in this that there are this is the innovative method. So what happened in this, like these cells from the tumor mass get detached and cross the barrier, the blood and tissue barrier, and then they circulate in the bloods. So what we do is we capture those cells or DNA, tumor DNA, and we analyze those molecular factors to get the picture about the whole ecosystem or microenvironment of the tumor in any patient at any time of the therapy or even before the detections of it. Okay. Breast cancer is very heterogeneous. We talk about BRCA1 and BRCA2 a lot. I had a sections like last month, and they asked me the questions that we know that there is a lot of communications that if you are susceptible of cancer, if you have family members who have cancers, then you should do a screening for BRCA1 and BRCA2. And is it enough? And my answer was no, it's not enough, because BRCA1 and BRCA2 are the most studied one, and most of the doctors and most of the medical professionals, even us, we recommend it for the first line of screening. But there is just chance that they will be negative on BRCA1 and BRCA2, and they will have to go to the extensive BRCA panels or any other kind of cancer panels to realize that they might have the mutations in those genes that will be causing them cancers in the future, or maybe at the time that they are getting the diagnosis for the disease. Single biopsies, missed temporal and spatial evolution. This is the reality that we are dealing with right now. Because in tissue biopsies, the thing is that we are taking the sample from the area of the cancer development. So we are taking the biopsy from there and we are doing the analysis, we are doing the microscopy, and everything is fine. But during the therapy, the thing is that the cancer cells have the ability to progenerate and make a mass in a really short time. And with it come the complexity where the DNA information that is present in the cells change in the meantime again and again during the whole procedure of chemotherapy. So you can detect it at the sometimes at the first time, but after deep treatment, there is a chance that the DNA information changed and the cancer cells becomes more intelligent and more invasive of the therapeutic procedures that we are doing at the time. So at this times when the biopsies or the tissue biopsies becomes incomplete, kind of like, then we go for blood biopsies. We check the DNA, especially the ctDNA, which is tumor cell DNA, which is present in the blood, and check if there is any more changes in the DNA that would be causing the therapeutic defect or the ineffectiveness of the therapy. I already mentioned some of it, that the liquid biopsy, currently we are defining them into three types. One is the circulating tumor cells. There would be cells that get detached from the tumor and are circulating in the DNA. They are very rarely present, but we can still detect them with our technologies. Then there is a circulating tumor DNA. DNA is the DNA from these cells that actually revolves in the blood at any given time during the disease. And exosomes are actually the vesicles, kind of like thought like is a circular balloon that would have a little bit of a DNA, little bit of an RNA, and little bit of a protein from the tumor cells. And they can give us information about how the tumor is progressing and what is the reality of the cell surface and how it is actually invading the therapeutic system. So we can use these molecular biomarkers to detect the type of the breast cancer at any time. Advantages. First of all, the advantage is simple. It's not invasive. You don't have to go for aggressive biopsy sections. You just have to have one prick of a needle and you can just collect the DNA. We usually do it for just 10 ml DNA, and we can have it again and again during the progressive stages of the DNA, even during chemotherapy or radiotherapy. So that's the main advantage of this therapy. The second is that, like I said, this real-time monitoring. So in biopsies and other kind of imaging, you have to make systematic screening or systematic imaging after a timeline from 1 month to 3 months. But this kind of this approach can be used at any time, and it can give you a real view that either the tumor is still persistent or in the blood, or is it possible that because of your therapy, which is very effective, the tumor titer in the blood has decreased over time. Okay. But like every approach, I will actually admit that this has limitations because breast cancer, it can metastasize. It can travel all around the body, but you can detect it, but you can't know where it is coming from and where the tumor mass is actually existing in the body. So it can't give you the whole picture of where you are detecting it from. So it has kind of a limitations. You can detect it, but you won't know where it is coming from in the blood. So for that, you definitely have to go to the spatial mapping, which is the next topic of my discussion. So spatial mapping is mapping where we actually do say that for the liquid biopsy, it's just a detection of a tumor in the body, but with spatial, you know where it is and what is the tumor and know how it is invading the therapeutic system or the immune system. That's very important for the constructive therapy. So what we're doing here is that we actually take the biopsy sections from the cancer patients, and then we use probes, microbial or molecular probes that are actually gene specific and also the surface gene specific like CD123, and then we use those probes and attach them on the tissue. After we attaching them, these probes also have a barcode. Barcode is something that tells us from where the actual information is coming from, whether it's from the tumor cells or the environmental cells which are around the tumor and making it possible for the tumor to grow and also invade our therapeutic system. So we use those barcodes, we take the DNA from the cells, and then we do the NGS process, which is the next generation sequencing. Next generation sequencing is a technique where those DNA segments from each of the each of the tissue sections are actually sequenced, and once they are sequenced, we refer them to our reference genome and see that if there is any change in the sequence of the DNA from the normal sequence or from the common sequence that is present in everyone anywhere at any time, and to see if where mutations are existing and how those mutations are causing the disease. We also report these changes in the form of gene mutations. We tell them, okay, this is the gene, here is the position where this gene is changing into something else. This not actually making a good protein, and that is how you are not being able to detect the surface protein or the surface epitopes that we use for the cancer therapy. and they are getting invaded. So what happens in those cases, if you know the genetic morphology of the DNA cancer cells, you can actually use the personalized medicines or personalized medications for them. There are a number of FDA approved cancer therapies that actually depend upon the cancer morphology. They actually depend upon the gene mutational changes. They ask you that what kind of gene mutation is present in your tumor cells, so that on the basis of that, they give you a therapeutical options that actually are more effective rather than the most prevalent one or the most common therapeutic options. In spatial mapping, like I said, we do the genetic changes, but there is a term that you will be hearing a lot in spatial mapping, that will be spatial transcriptomics. Now, what happens in spatial transcriptomics is that we are not just sequencing the DNA, but we are also sequencing the RNA that are present in the cell at any given time to get the picture about how the cell is expressing and what kind of proteins or what kind of the enzymes are in the present that are causing the proliferation of the cells and are also causing the metastasis of those cells. So at any given times, you can have an information about all the RNA expression levels of the tumor cells, not just the tumor cells, but also the cells that are present in the vicinity of that tumor cells. So you can get a whole picture of all of the environmental factors that are helping the tumor cells and target those RNA products or those protein products to actually be able to effectively do the therapy and effectively do the chemotherapies and make them less aggressive for the patient as well. Spatial mapping in breast cancers not only reveal intratumoral heterogeneity, because even if it's a tumor, the genetic changes will cause the tumor to have a different kind of a DNA morphology even in one tumor cells. There would be like, if you think about like there are 100 cells, 20 of those cells will have a different information, different RNA and DNA information, and 10 of them will have a different information at any given time, which actually complex the overall eradications of these tumors from the cells, and there is also case of reoccurrence of the cancer in patients after a few years. So these detection methods not only help the therapeutics, but also they can be used in the screening methods after the therapy. We can have this screening method after 1 year or 6 months, and continuously monitor their blood streams to check if the tumor is actually resistant in some way in their body and actually invaded the chemotherapy. So it can give you a whole picture of the tumor in a molecular way, in a DNA way. So DNA way is kind of different because we deal with just genes. We try to decide how the tumor is actually happening or how the breast cancer is actually happening in the body. And we try to come up with therapeutical options that are the best for our patient at the personalized level. You have heard about, I'm sure everyone knows about PIK. So PIK is one of the examples where the genetic changes in the gene actually causes to be irresponsible to the therapy system. So what happens that there is a technique where this spatial transcriptomics is actually FDA approved techniques where they do the transcriptomics. They realize that okay, this gene is actually changing while it's also evolving. So they have a therapeutic system different from for those evolving changes, and it's actually given a much better results than the common therapy that we use for this cancer. The thing is that liquid biopsy and spatial mapping are actually experimental. There are only 2 or 3 biomarkers that are actually FDA approved at the moment. But the thing is that we need to use these technologies, the liquid biopsies and the spatial mapping together to make it possible for us to have a better prognosis and better better idea about the cancer load at any time in the body. This is the case that actually is an example. There is a 52-year-old woman who was hormone positive, hormone marker positive and HER2 negative in breast cancer. She had a treatment with the surgery and she was also on endocrine therapy. And then there was a biochemical and radiological remission. So what they did, they took the ctDNA, which is the cell-free tumor DNA, and monitored the ESR1 gene. And they realized that there are mutations in the gene that were actually invading the therapeutic options they were using before for the patients. So what they did, they actually changed the whole therapeutic mechanism of the patients and started a different kind of treatment, which actually not only becomes the early interventions because they weren't able to actually detect it by screening or by tissue imaging. They actually were able to detect it very early on just by DNA from the blood. And they also actually realized that because of the therapy, the tumor became more intelligent and also knew that how to invade the therapeutic system. So the second time it came back stronger than the first time. And if they were going to use the same therapy they've used before, it would have been useless for the patients. It wouldn't have made a single difference for the patients. But because they were able to detect it by ctDNA, they made a remarkable recovery even at the second time when there was a remission. And it became a more rational treatment option for the patients because otherwise it would have been a very delayed change for the patient if they were doing the endocrine therapy and they were like not getting the results, and then they did screenings, and then they did MRI, and then they realized that okay, the therapy is not working. That's a long procedure. So they saved the patient from that procedures and just did the simple DNA test and realized that we have to change the therapy. Clinical implication and future directions will be included in this precision oncology beyond biomarkers. We do know that biomarkers are important and we do it in our detection method for breast cancer or any kind of other cancers, but there is a need to actually look for beyond ways for new detection methods and become more smart when we detect cancer in our patients. We need to base our adopt based on tumor ecosystems because we discussed about tumor as an entity, but we don't realize that the ecosystem, the microenvironment that they have around their cells is also important to know how they work and the body system at any given time. It also may involve, if we know more about the molecular basis of breast cancers, we will be able to provide a more personalized medication system for each patient with their own requirements rather than go with the common ones that might be detrimental to their health in the long run. So breast cancer is especially in topology heterogeneous. It's really heterogeneous and it could change not during the prognosis from one patient to another, but also during the implication in the one cycles. And then there is liquid biopsy as non-invasive, like I said, and spatial mapping, discovered tumor microenvironment complexity, and that complexity is also in study right now. I don't know how to say it, but we are actually very early in the discoveries about the cancers, and we still think that there is a room for research and to understand the genetics of the cancer, especially in countries like Pakistan, where people don't actually focus on the genetics too much. They just focus on the treatment options or how to manage the disease. But if we can have a more precise molecular genetics analysis, then we might be able to give a better treatment to our patients here in Pakistan populations, just like in other first tier countries. And thank you so much.
So here we conclude the second session. Any question from Dr. Prima Fatma regarding the Dr. Tahir, question?
Thank you, Dr. Priya. Excellent talk. This is Dr. Tahir Bashir from Faisalabad Medical University. I have a query that is this liquid biopsy is equally competent for detecting germline and somatic mutations? And do we, anticipate to see less and less of the reflex testing with tissue if we think ctDNA has become so profound that ctDNA or, and lastly, what is cell-free DNA? I mean, we generally go through these terms.
Cell-free DNA. Okay, I will start with the somatic and germline. You asked that questions, and it is possible to tell the whether the tumor DNA that we are detecting with our method is somatic or the germline. We do the sequencing of the whole DNA, and we have the markers that are specified for somatic, so you can analyze it and tell at the analysis level that whether it is somatic or germline. That's possible. Secondly, your question was about about cell-free DNA. So cell-free DNA, how should I define it? All the cells in our body, they multiply, they have a short life, and after that they will die, they will disintegrate. But DNA is a very stable molecule and whole. So what happens is, even if the cell disintegrate, the DNA from all of the cells actually float with our blood streams and stay in our body for a little longer than the cell. So what happens is that we take the DNA, we don't disturb all of the leukocytes, because leukocytes are the only blood cells which have a nucleus and which have a DNA. We don't disturb those. We make sure not to disturb those, and we only capture the cDNA or the cell-free DNA from the blood. We do this not only for the tumor, we also do it for NIPT results. I think you have heard of it, non-invasive prenatal testing. We're actually doing it in Chuktai lab as well. What we do, we capture the DNA, we amplify that DNA, that's just a chunk in the blood, and then we sequence that DNA. We sequence it, and then we align it with the reference genome, which is present on all of the websites, NCBI, and UCSC. You can get that genome data from anywhere. And it's then after aligning those sequences with our reference DNA, we read those sequences. We define where the mutations are happening in the sequence, and we also define whether those differences are in the cell-free DNA or is it a noise from the somatic DNA that might be present in the normal cells. Then after analysis, we make sure to report those mutations with locations and their changes. And we also make sure that we do the whole in silico studies, where we actually study each of those mutations and go to the reference data from NCBI and all the scientific databases, whether it is reported or not, what kind of a report it was in, what kind of a disease it was causing in those reports, and what are the prognosis and what was the therapeutic methods. So we do the deep end analysis on those, and then we actually report that data to the patients. At the moment, we are only doing in Chuktai Center, BRCA1 and BRCA2. We can get the DNA, and we can do it from screening method as well. Like if it's a normal person who has a history of cancer in their family, they can come to us. We can tell them if they are BRCA1 or BRCA2 positive. But we also do it at the level where we actually outsource over the samples to the reputed labs in UK and also in Germany, where we actually do the whole panel, extended panel for breast cancer as well. Same is done for the CT tumor. We are doing it at our level as well. We actually take the sample from here, and then we outsource it, and then we reanalyze those results and then publish it for the patients. And anyone have any queries about the genetic mutations or how they can better consult their patients, we also do the patient and expert collaborations as well. And we talk with the doctors, and we try to come up with the more better options for the patient as well in the meantime of their treatment. Thank you.
Thank you so much, Dr. Priya. Now we conclude the second section, may I request Dr. Vasudha to come on the podium for the sheet distribution, and Dr. Takushi as well, and Dr. Somer as well. May I request Dr. Majbeen to also come on the stage, Dr. Isha as well, Dr. Sanur Rahman as well. So our first presentation for the second session was from Dr. Fatma Manali regarding the biomarkers and molecular subtypes in breast cancer. So I request the sheet to be presented to Dr. Fatma Manali. We have a clap for Dr. Fatma. Second presentation was by Dr. Friha Fatma regarding the role of liquid biopsy and special mapping of breast cancer. Thank you so much, sir. Thank you. May you have all seats. Now the tea time is there. We will be having a tea break, and then we will restarting our third session regarding the systemic therapies and medical oncology. It would be a wonderful session. So I request all of you to have joined back from this tea break. Thank you so much.